Well, I want to begin the meeting by thanking you all for coming. This is an important topic to all of us. We're all wondering just where this palliative care is going. There were a lot of good things that were likely that when you talked about this about a year ago that were going to be happening, and we're anxious to hear about them. Um, but before we start that, I want to introduce Kim Finger. She's the other co-chair. Uh, yeah, she's waving at you. Uh, I'm not sure all of you have had a chance to meet her yet, but you certainly will. Uh, so with that, let's begin the presentation. We have three people from PeaceHealth here today to talk about palliative care. Give us an update. Donna Inglis, she's the St. Joseph's PeaceHealth Foundation Board Vice President. Amber S. S. George S.
Asbjornsen. I know it's a
Thank
tough.
you. I am tripping over words today. um, she's the philanthropy from officer from PeaceHealth, and Leslie Clements, the director of palliative care at PeaceHealth. So I imagine you have talked among yourselves and know the order and how you're going to present this. So I will turn this over to you.
Thank you. Well, I just want to start off by saying a big thanks for inviting us back to give you an update on palliative care up in the Northwest Network. We really appreciate your time and your ongoing support. I'm wondering if everyone is able to see my screen.
Yes.
Yes.
Yeah.
Okay, I did it. It's awesome. Okay. Okay, let's go ahead. No, there's like a way to, okay. Okay, I'm gonna give you an update on our outpatient program and our inpatient program up in the Northwest Network. And please feel free to hop in anytime with questions, and we'll have time at the end for some questions. Again, I'm Leslie Clements. I'm the System Director of Palliative Care. And a little bit about me, I've been a palliative care clinician for 20 years, and I've been in palliative care leadership for 10 years. And 8 of those 10 years, I've had the great pleasure of being with PeaceHealth.
Leslie, if you click on slideshow at the top and start the slideshow, you'll lose the rest of that.
Thank you. Let's try it. Okay. Ooh. I don't know what that is. Got it. Okay. See, I like it when people are smarter than I am. Okay. So this is our team up in Bellingham. So on the left here, we see our outpatient team. Thanks to a lot of community and foundation support, we have a lot of people on our outpatient team. And we have Maggie Glowitz is our nurse practitioner. Katie Smucha is our nurse. She's been with us for a while. So is Devin, our social worker. We have Katie and Sabra as our pharmacists. Candace is our chaplain, and Drew is our MA. In our system support, we have a system referral coordinator that helps with all of our referrals and scheduling and coordination of prior authorizations for our visits. Here are our locations. We have an inpatient team. We have support in our cancer center, although they see all kinds of diagnoses there. So it's just a clinic essentially. And we do home visits. Our leadership in the Northwest Network, we have Claudia Fisher is the local manager over inpatient and outpatient in the clinic. Samantha Watson is our outpatient program development manager for our system. We have Dr. Angie Lee, who's the medical director, myself as the system director, and then these are our inpatient team. So as you can see, again, I want to reiterate, this is thanks to a lot of community support in Bellingham. We have 2 really robust inpatient and outpatient teams up in Bellingham. This is a little bit about the referrals for our outpatient team in Bellingham. So you can see our goal for calendar year 24, after we had a big change in our staffing model and we started to rebuild, we changed our program to a consult-based model, where we see our patients, establish what their acute palliative care need is, and then work to meet that need. And after changing our model, our calendar year goal was to see 460 distinct patients, and that goal was exceeded. We saw 482. And you can see just a steady, ongoing, continuous growth of the census. And down below, you can see our capacity. So we still have a little bit of room, but we serve a lot of patients in the area. This is about when we get our referrals. So we're really hoping to move getting our referrals earlier up in the Bellingham community. So we all know that hospice is prognostic specific, which means two physicians deem that a patient has less than 6 months to live if their disease process were to take its natural course. And so we're really wanting to see patients prior to that period. So here we can see, and up in Bellingham, we see about 70% of our patients inside the last 6 months of life. So we're really partnering with our referral sources in the community, in the medical group, other clinics, and in the hospital to get these referrals earlier. Our goal is to move from 70 to 40% of our referrals within the last 6 months. And increase the amount of time these patients are having on hospice. This is a graph of our hospital and emergency room utilization. So you can see having outpatient palliative care decreases the amount of time people are utilizing the emergency room and being admitted to the hospital. Now, why does this matter? I think we all have personal experience where we know what it's like to have a loved one be hospitalized, and just how upsetting that can be to them, to their routine, to their loved ones, the upset in their life, the time they spend. So in outpatient palliative care, our goal is really to manage your chronic disease process better at home and have you living a life that aligns with your idea of what quality of life means. So good symptom management and optimizing your time out, living your life with your loved ones. So the first graph on the left is the utilization prior to an outpatient palliative care consult. The bar on the left is the utilization post. So we can see here there's a 32% decrease in hospital admissions. So 35 less admissions. It's a 21 decrease in emergency room visits. It's a 57% difference in payments and a 17% decrease in the number of patients. So the other thing is we know that the cost of care for patients with chronic illness is quite expensive to them and to the system. And so this also puts money back into their pockets, which also enhances their quality of life. This is just another view of the same information, but you can see now the bar on the far left is 90 days prior to the outpatient consult. Then we have 60 days prior and 30 days prior. So we just see a real ramp up in their utilization of care. And then this is when we get consulted, this green dotted line, and then we see a decrease that is sustained 30, 60, 90 days, and actually more pronounced 90 days out of decreased utilization. So more time at home. So again, an earlier slide talking about the time from when we're getting these referrals. So we're really working with our referral partners to move this green line from here and between here. That's even less time for people to be in the hospital and emergency room. Our inpatient palliative care update. So here is an overview, a 6 months viewpoint of all of the work our inpatient team does. I know it's a lot of information, so I just want to pull your eye to a couple of things. We see a lot of patients in the inpatient setting. So you can see just in March, we did 348 visits. 97 of those were initial consults. And so the rest were follow-up visits or tuck-in visits. Here you can also see, and I have a graph that will show this just a little bit more visually, but if we get a consult within 3 days of their hospital admission, we decrease their length of stay in the hospital. So consults within 3 days of hospital admission, your length of stay days on average is 5. Consults we get after 3 days of hospital admission, your length of stay day average is 12. And so I personally have never heard anyone say, you know what, I really wish I was in the hospital longer. So decreasing that for patients, getting their goals clear on the front end of their hospitalization, and walking alongside them to get them home is our goal here. So the delta, the difference, is 7 days. So that's a big quality of life boost for our patients. We track when we see our patients. So consults completed, our goal is within the next day, earlier than the next day of the order. So up in Bellingham, this team just really knocks that out of the park at 82%. Hospital penetration rate, a robust, mature program, we're going for 10. So we can see January, February, Bellingham team was at 10, March they were at 9. So we're really close to that. And then at the bottom here, patients who died in the hospital, we see is a lot less than the national average, at 9%, which is great. That means we're getting patients home to their loved ones and they're not spending their last days in the hospital. We can also see we have a higher percentage to hospice than the national average up in Bellingham as well. Again, we track our timeliness. So percentage of consults completed within 3 days of admission. We don't have control over this, although it represents our partnership with our referral sources, which is really great up in Bellingham. So our goal is at 50%. You can see for the most part, we meet that. And when we don't, we're at 49 or 48. So we meet that pretty consistently in Bellingham. The graph below is consults completed within the same day or next day of order. So our target is 70%. And the reason it isn't 100 is we're a Monday through Friday, 8 to 5 service in the hospital. But again, even with a high goal like 70%, Bellingham team still meets that and exceeds it. Here's just another visualization of the length of stay difference for earlier consults. So the blue bars are the consults we get within 3 days of their admission. The orange bar are the consults we get after 3 days. The yellow bar is the delta, so the difference. So we can see month over month, this makes a huge difference. So again, working with our referrals, getting these consults earlier. Up in Bellingham, they do a great job of that. It's 284 hospital days avoided in a month, which again means more people at home, comfortable, feeling well, living their life with their family and not stuck in a hospital. We also track our hospital and emergency room utilization for our inpatient consults. So here we can see on the left, this is 45 days prior to an inpatient consult and 45 days after. So we have a 41% decrease in ED visits and a 29% decrease in hospital admissions. And then I said, well, maybe 45 days is too short. Maybe that decrease just represents that they were just hospitalized and had a workup. So I wanted to see these numbers 6 months before the consult and 6 months after. And as we can see, they're more durable and sustained over time. So 6 months before, their admission and emergency utilization is 99%. 6 months after, it's 44 and 49. So that's a 55% decrease in emergency visits and a 50% decrease in hospitalization. So again, having patients home longer with their loved ones. So that is a update on the outcomes of our outpatient and inpatient teams up in Bellingham. And again, we wouldn't be able to do this without the support of community members and people like you. So thank you so much. And I'm here to answer any questions you might have about our wonderful program.
I'm not seeing any questions in the chat. I don't see any hands raised. Are there any questions about this part of it? Ah, Kim.
Hi. Leslie, could you refresh my memory, or actually I'm kind of new to this. So you said about the change to a referral basis for the outpatient palliative care. What was it before? What's the shift?
Yep, so we changed it to a consult-based model. So previously we would get a referral and have patients on service essentially until we transition them to hospice. And what we found was there was work on the front end to kind of manage the reason they got referred to us. And then there was work on the back end to help them transition to hospice. In the front end, they were largely stable. And so we were having patients where we were just, we had them for keeping up space on our census, essentially. So with a small number of clinicians, right? Our consult model is we're seeing the patients when they needed a lot of help, and then when they need help that might pop up through the thing, and a referral to hospice. So essentially we say, what's your acute palliative care need? We meet that in a couple of visits. We sign off. We say, should anything change? Should you have a hospitalization, a new diagnosis? You're not feeling well, call us back. We'll sign you on. We'll go back out, see what's going on, get that need met, sign off. So with that, our community footprint, because we have an ongoing rolling census where it's just the really acute palliative care needs. So we're able to see, the 482 patients, that's almost triple, 2.5 times what we were able to see on the previous model, if that makes sense.
So it's mostly just a change in how you account for your patients. It's not a significant change in the care you provide.
No. It was just a way to say, how can we see more patients with the staff available? People living in our communities with a life-limiting chronic illness, that number is huge. And in a lot of the communities PeaceHealth serves, we are the only palliative care program, right? So really trying to be judicious with this resource and touch as many lives as we can.
And in Bellingham, you are the only palliative care service, correct?
Correct. Yeah.
Thank you.
I see a question in the chat. Someone was wondering how PeaceHealth's redemption through suffering, and I think that refers to the bishop's directives on the care that's to be provided, how redemption through suffering, that belief is reflected in palliative care.
I'm wondering, Pauline, would you mind coming off mute to say more about your question?
Sure, my internet's kind of unstable. So yes, I believe that is part of PeaceHealth's philosophy, that there is redemption through suffering. And that seems like an interesting thing to think about, how that might integrate with palliative care. So I'd love to hear how you hold both of those concepts and provide palliative care.
That's interesting, because actually in our mission statement, it is to alleviate pain and suffering. So that is the PeaceHealth verbiage around our mission statement, is to alleviate suffering every time, every touch. And so then palliative care is really, obviously I am biased, but it is the mission of PeaceHealth, right? We are here to alleviate suffering. And so that is what our primary driver is in palliative care.
So that directive about redemption through suffering doesn't apply to the hospital service at all?
No,
I'm just
and it's not on the
confused how
hospital
that
service.
religious mandate fits into your specific area of work.
Yeah, I think there's the larger, Catholic mandates, and then there's organizational mission statements. So our mission statement as a healthcare system is to help to alleviate suffering. Now, that being said, I
Mhm.
will say, in my 20-year career, patients suffering with chronic illness, there is a lot of suffering. So palliative care coming in to alleviate the suffering does not eliminate the suffering.
Mhm.
So there isn't a way. If there was a way to say this is the path towards no suffering with a chronic life-limiting illness, well, we would really love to provide that. But suffering can be alleviated by accompaniment. So we walk alongside people. A lot of healthcare, if you think about it, a lot of people are trained to cure and to save. And so in palliative care, our aging population gets to a certain point where sometimes the treatment interventions are worse than the disease. I'm trying to, in an overly simplified way. Cancer is a good example of this. Chemo is a really hard thing. So putting somebody on chemo who's a 45-year-old is one thing. Putting someone on chemo who's an 85-year-old, you are not going to have the same outcome between those two patients. One is going to have a harder time with the treatment than the other. And so in palliative care, we're saying, how does that align with your concept of quality of life? Like, well, my concept of quality of life is I don't want to feel poorly. So that's what one person might say. Another person might say, my concept of quality of life is I want to live as long as possible to see my next grandbaby born. Those are two different things, right? This person, we're going to say, well, then you'll want the chemo. You won't feel very good, but it can help extend your life. This person will say, oh, well, not doing this probably shortens your time, but then the time you have, you will feel better. So that's what's in alignment with their goal. Does either one of those really completely eliminate their suffering? No, but it's a conversation around how do we get you the information you need to feel empowered to speak into the space around what's important and meaningful to you, and how do we help hold that line so you're getting goal concordant care, you're getting care you want and not care you don't want.
So if I can sneak one last question in, is that okay while we're,
Yeah.
so if you reach the point in your hospice care where you want to, trying to think how to phrase this, receive a higher level of pain-killing drugs than would be consistent with continued life, will you be able to receive that through PeaceHealth's palliative care team?
So that's the point at which we would transition you to hospice care. Hospice then is able to prescribe pain medication for symptom management at higher doses than most other service lines. So palliative care, we are able to prescribe higher than your average acute care setting. So we have more options to go from here to here. And so this is, how we can help manage your symptoms. And then hospice, would go from here to here. And then there are even things within hospice. They have a level of care called general inpatient care. So if you're in hospice and you're at here and your symptoms are still not managed, we can move you to a hospice house and work to manage your symptoms around the clock. If that answers your question.
Sort of. It's really a death with dignity. I mean, we've got rights in the state of Washington that I don't think are in compliance with PeaceHealth's
And then
philosophy, I guess.
Yeah, this is a great opportunity to just, I'd like to take a moment and really pause and reflect on the loss of our Pope today. And so thank you for that. He was wonderful, and he helped advance the Catholic faith in a lot of different ways. So it is much more congruent than it used to be, if that makes sense. So the death with dignity policy is that you have to be well enough or have a condition that enables you to take the medication yourself. You have to put it in your hand, put it in your mouth, drink the water yourself. And that's going to be the case no matter what hospice service you are. That is the death with dignity law in the states. So there are patients with certain conditions where they immediately don't qualify. You have dementia, you cannot consciously make that decision for yourself to put it in your hand to take it. You do not qualify for death with dignity. You have neurological conditions, ALS, Parkinson's, where you just physically cannot get a pill from your hand to your mouth. You do not qualify for that. So with PeaceHealth, you can utilize death with dignity. We are not able to be in the room when you administer the medication to yourself, but we will come back in the room afterwards to provide you with care.
And your doctors wouldn't prescribe that, of course. So it would have to be a non.
We can do one of the requests. The
okay.
hospice doctor
That's good to
cannot
know.
do it because you can't have someone actively involved in your care be making that. So our hospice physician wouldn't do it. But if your primary care physician is with PeaceHealth, they can make that first request.
Oh, okay. Thank you. And sorry for hogging the questions, folks.
No,
Thank
no. These are great questions. Thank you for asking them.
Uh, Kate, I think she has her hand up.
Yeah, I was wondering, I mean, I wanted to talk about the fact that, you know, your statistics are great at looking at getting people moved out of the hospital quickly or out of the emergency room. And having been involved in caring for some people and their families, sometimes that rush or that shorter time period feels like they're being pushed out. And maybe not just the patient, but the family. You know, they're elderly, they're trying to get their act together so that the person can either come home and move into hospice or whatever. So while I think that statistic is good in some ways, I'd question that you've never heard someone say, I wish I was in the hospital longer, because I know of people personally who do. You know, they're like, I need someone to take care of me more, to get more settled with this whole thing before I move on. So just keep that in mind.
Well, I'm happy to also address that too, because those are two different things, right? What we're tracking in our referral is if we see you so we don't impact length of stay on the back end of a hospitalization, right? Length of stay then is really impacted by, on the back end, that's a care management thing. So that's getting the social worker in, the nurse in, the doctor, that care management team to say, what do you need to be able to leave the hospital safely and with your things in order? So is that durable medical equipment? Is that a referral to home health? So those are the things that can, starting that conversation early once we know this is what the plan is and this is the direction they want to go. Let's make sure they have what they need to go in that direction. That's a care management way to address length of stay on the back end, is helping to support people feel like they get things lined up. Now, how palliative care addresses length of stay is on the front end. So when people come in and they have 5 different options, you could do this, you could do a combination of these things, you could do none of it, you could do, and they don't know what to do. And you're hearing from the hospitalist, one thing, you're hearing from the cardiologist something else, you're hearing from nephrologist something else, and your head is spinning and you're trying to make a decision about what makes the most sense to move forward. This is where we can be really helpful, because we come in and we say, what's all the information all of these people are giving you? What's really important and meaningful to you in your life? What's the outcomes of all of these possible options? And then we help them decide. We'll take a little bit from column A, not so much from column B, a lot from column C, and a little bit from column D. And we say, okay, great. And then we go out and we talk to the hospitalist, the cardiologist, the nephrologist, and we say, this is what's really in alignment with what they want for their care needs. And we get a holistic plan going for their hospitalization. And without that, deciding this with multiple providers focused on a lot of different organs that can take up a lot of time in the front end, and that increases the amount of time overall patients are there. So it's not a rush out on the back end from palliative care. It's really saying, what's the best use of our time here? What is a plan most in alignment with what you want for your hospital stay going forward, which is why we're asking for these consults within 3 days of the admission.
Thank you.
I see two questions in the chat, and then I also see Catherine has a question. Do you want to take some of those in the chat?
Sure. Is referral to your service self-referral or provider referral? So it's both. We do need an order from a physician, but we have plenty of people call and say, my mom could really use this, or I could really use this. And then our referral coordinator and our MA would work with whoever's calling to get a hold of their physician for an order. And then we get referrals from the hospital, we get referrals from specialty clinics, we get referrals from little primary care clinics that aren't PeaceHealth related from their providers. So it's both. Barbara, does that answer your question? You put in the chat.
Yes, thank you.
You're welcome. When a person goes home on palliative care, what services does that person get from you besides prescriptions for medication? Great question. So because we're a multidisciplinary team, it's really a holistic approach. So we have the nurse practitioner, and that's an assessment really around your symptoms related to your chronic illness. So again, we don't manage symptoms that aren't related to that. So people who have, oh, well, I'm X old and I've had back pain for 25 years. We're going to give that to your primary care, right? But I have congestive pulmonary disease and I have a hard time breathing, and that's upsetting to me and causes me anxiety. We're going to help you manage that symptom so you're less anxious and you're breathing easier. So that's the nurse practitioner. But the nurse really does a lot of trajectory of education of disease. So a lot of people don't know these are the phases of your disease. So this is when you get the diagnosis, and then these are the ways it progresses. These are the decisions you're going to have to make along the way. This is what you can expect to happen next, because we're serving patients that these diseases, they're progressive. So even with the best medical management, even with saying yes to everything that's offered on the table, you will continue to decline and you will continue to experience increased symptoms. So our nurse is out there educating, saying, this is what's next. This is what's next. This is what's next. Our idea is we don't want people to be surprised by this and caught off guard. We don't want people to end up in a crisis where they wouldn't know what they wanted. So doing a lot of education. And then our social worker does a lot of counseling and mental health support. So that's both to the patient and the family. Having a chronic illness, having to make these decisions, having to live with it, all of that is really challenging. So, we hear people say a lot, oh, dad's in denial about his condition. Mom won't talk about it. It's really, really upsetting. So the social worker's in there to say, how can I help support with these things, right? And it's not all at once that somebody comes to accept something going on with their body that's progressive. That takes time, right? So we have a social worker there to kind of help them through that. And then spiritual things. I think when people know their time is limited to some extent, that brings up a big question for a lot of us. What happens next? So we have chaplain to support with that as well. Minda, does that answer your question you put in the chat?
Yes, it means that there are home visits from the nurse practitioner, the social worker, and so on.
Correct. Yes.
Catherine.
Yes. It seems that when a lot people that I know here who do have palliative care, that a lot of their needs have to do with just getting through the activities of daily living. Meals and rest for the caregiver and so forth. And I'm just wondering, do you have agreements with certain home care agencies, or is the patient and family kind of on their own to find that kind of home care?
Well, we have a lot of information about who does those services in the community. So we would definitely help to connect with the resources and to communicate. And we've certainly gone on visits where we sit with somebody coming in and help them interview, well, remember, you also need help with this, and we need help with this, and do they do that? And then, so helping get people organized to figure out what the best service is for those needs, we do coordinate that.
Well,
Also, people who are needing a higher level of care, because that happens a lot too, right? Sometimes you get private caregivers in the home, and even that just doesn't feel sufficient at a certain point, right? So that's really, again, going back to disease trajectory and education. At what point do you need more help, and what do those different levels look like, right? What does an assisted living look like? What does a nursing home look like? What does an adult family home look like? What are the differences between those? How are those paid? Can we get your family on some tours once you decide which level you might like or want? So providing that education ahead of time, again, so it doesn't feel like a crisis if it comes up.
Thank you.
See, another question has appeared in the chat.
What are the primary diagnoses you are currently treating? Which chronic illnesses are you not able to serve? We don't have diagnosis limitation. So I know a previous model we saw in Bellingham, we saw 3 diagnoses. That's no longer the case. You have a chronic life-limiting illness and you are needing some kind of wraparound support with that. Please refer to us and we will go out and see you.
I had a question. What's next? What are your goals? This is where you are. Where are you headed?
Okay, hold on. Whoa. I'm trying to keep up with it. Where are we headed? In the inpatient side, that 10% penetration rate really has been our goal. And so now that is, let's hold steady there. Let's hold steady there and let's optimize these outcomes. So really thinking of more ways to track the outcomes, to demonstrate that, to talk about that. In our outpatient program up in Bellingham, again, the outpouring of love and support from the Bellingham community is astounding. It is really not, our outpatient programs across the system elsewhere are not staffed the way Bellingham is staffed. And the difference in that staffing level is the community support. And so our moving forward, my big goal is figuring out how to get these services better paid for. Financial sustainability and managing these services are really important. To me, this is my life's work. It's really meaningful work. So in the next year, we are embarking on a lot of contract optimization with insurance companies. And so I just ask that you all send us good vibes and prayers. Insurance companies typically don't want to give you more money, but as you can see, our outcomes really speak for themselves. Part of the benefit, part of the group of people benefiting from our service are insurance companies, right? When I can say, I'm keeping your patients happier, healthier, and at home, that costs your insurance company less money. So I am going to come in and say, I do want you to pay me more money because I do support you in these ways. So that ties into one of the questions that just got asked in the chat. How do families pay for these services? So they don't. There's some insurance companies require a copay, and then a family would pay the copay for that. Most don't. Medicare, Medicare Advantage, Medicaid don't require that. And so there is no significant cost to the family. Now, that being said, you heard me list off all the disciplines that go into this work: a nurse practitioner, nurse, social worker, pharmacist, chaplain. The only person who's able to bill for the services they provide on our team on a Medicare fee-for-service model is the nurse practitioner. So we have a lot of salaries and wages that aren't offset by the income we get from revenue. So again, going back to financial sustainability for these really important services, just optimizing all the different ways we can get these covered. So we have some revenue from the nurse practitioner, looking on value-based bundled contracting for our outpatient setting that covers some of these other disciplines, working with our wonderful foundations and communities to support these programs and having this care in their communities as well. And obviously PeaceHealth covers a lot of the cost for us too.
If Medicaid cuts go through, they may affect some of this. Do you have a backup plan or what you will do in that case?
Yeah, PeaceHealth, again, is mission driven to serve the most vulnerable people in our community. So what happens is we just won't get paid, and PeaceHealth will come up with a way to write it off. So these are hard, challenging financial times for healthcare, and I'm really hoping to get these contracts optimized to offset some of the other things that might come through with Medicaid. Because anyone then with Medicaid, we would not receive payment on, but we would still accept them. That is part of our mission. So again, it's really talking about diversified financial support.
Yeah, and that's a really important role that philanthropy can continue to play. You may have noticed we haven't been actively fundraising for palliative care, but we really were doing that purposely because we wanted to allow for the time for the program to grow and thrive as you see it is right now, which is so great. But that was important to us that we wait until we felt like the program was ready to start fundraising. And we haven't kicked off fundraising for palliative care yet, but it will be something we'll start considering doing so that we can continue to support the program. And as a reminder, for those of you who were here, and for new news, for those of you who weren't the last time we were here, I shared that the foundation itself has committed to support palliative care over the next few years. We've set aside $1 million to support the program over the next few years, and we continue to check in with the program every couple of years to renew our connection and our contract. And so that next opportunity will be at our June board meeting. Leslie came and presented at our March board meeting, which was so great, and our board members were really thrilled to see the progress of the program.
Thank you, Amber. I'm going back to the chat. I'm trying to stay caught up here. What ratio of clinic-based palliative care visits and home-based is our current program? It really is about 50-50. So we have patients who come into our clinic and see our team there, and we also have about 50% of our visits are home-based, which I think answers Marie's second question and Mickey's first question. But if either one of you have anything you'd like to tack on to that, let me know.
No, you answered it well, thanks.
You're welcome. Barbara, certified social workers can bill for psychotherapy with Medicare. How come it cannot work with palliative care model? It does work with a palliative care model, and that's a really good call out. Thank you. With the palliative care model, because our social workers do heart counseling and then all that resource coordinating. So going back to a previous question about if we need to help them get in-home caregivers or help them find a higher level of care, all that resource coordination is also what social work do. But the part of the social work interventions where they are providing counseling can be billed.
Right.
And so the requirement for that is you need a licensed clinical social worker to be able to put forth that bill. So the social worker in Bellingham is in the process of obtaining her LICSW and should have it here in the next 2 months.
Excellent. And a revenue resource for you then too.
Exactly.
Yes.
Exactly. Like many people are still confused between palliative care and hospice. How do you educate the greater? Julia, this is the $1 million question. I feel like we go about this in a lot of different ways. And in my 20 years in palliative care, I think I have just come to accept that this isn't a one and done kind of thing. We educate on this everywhere on an ongoing rotating business. So We have community events where we go and talk about the difference between palliative care and hospice. We have to educate our own system sometimes too on, people who refer to us. When would you refer to palliative care? When would you refer to hospice? So we go to a lot of groups, a lot of doctor meetings, a lot of nurse meetings, a lot of care management meetings. Everyone is our partner in the hospital. So that is just this ongoing relationship, rapport, communication. I come to things like this. This is a great opportunity to talk to people who talk to people, right? You guys are out and talking to people about things that are offered and going on. So if you know the difference between palliative care and hospice, you can help have conversations with your community about it. So I try to educate. I call them my palliative care champions, right? In the hospital, I have people on each unit and in every service line that's just really passionate about this work. And so making sure we keep them educated about the changes in our program and things that are going on, making sure I'm coming and talking to community-based players that support us and answering their questions about how the program's changing and evolves. That just helps to continue educating. I try to have people who are informed in as many places as humanly possible. I don't know if that answers your question, but it is a never-ending conversation.
I think that it gives us something to do after the meeting. We need to go out and talk to our neighbors.
Yes, go talk to your neighbors. Go talk to your neighbors. Can you better define the next few years, please? Yep, this year is a lot of financial security, sustainability. So we're doing contracting, we're standing up social work billing, we're doing those things. The following year, we're going to work on our community access hospitals. So one of the things that PeaceHealth a lot of people don't know about is PeaceHealth has the big hospital systems. There's 5. And then we have 5 community access hospitals across our system. Up in the Bellingham area, there are 2. So really working on how to get those smaller, more rural communities access to palliative care and getting that set up as well. And then I'm hoping with increased contracting optimization that we're going to be doing from this year, that we're really able to grow. I mean, the truth of the matter is the amount of services we can provide is directly correlated to the amount of people that we have able to provide the services. So we're having a more financially sustainable reimbursement system, then we're able to increase our FTE and our caregivers on our team, which then increases our reach into the community. How can the wider community help put pressure on insurance companies to fund palliative care services? Oh gosh, that's a really great question. And I really appreciate the question. There are organizations, the Washington Organization for Hospice and Palliative Care is really advocating at a federal level and a state legislative level, but there's lots of opportunities to volunteer with groups like that, to go and talk to our Congress people and our representatives about different reimbursement models for palliative care. So there's me kind of fighting this on the individual insurance negotiation component, and then there are other people kind of coming in from the top to make permanent lasting changes on a reimbursement structure. So there are lots of opportunities to get involved in that way. Mary, what is the easy answer to palliative care versus hospice? Yeah, so hospice is prognostic driven. So that's 2 physicians saying if your condition were to take its natural course, so not undergoing aggressive treatments, so not undergoing IV antibiotics, not staying on chemotherapy, those things. If you're really focused on comfort and your disease taking its natural progression, that you have 6 months or less to live. And then comfort around that 6 months is the whole goal of hospice, making sure you're comfortable as your condition progresses through those last 6 months of life, is hospice's goal. Palliative care goal is, we're really thinking about your chronic illness. So once upon a time, this is why people get confused about the difference. Palliative care didn't even exist because there weren't a lot of treatment options available to people with chronic illnesses 60 years ago. You would get a chronic illness diagnosis. There were a couple of treatment options, a couple of medications, maybe a surgery. And once you kind of went through those, your doctor would say, it's time for hospice now. We don't have anything else to offer. In 2025, we have a lot of things. We can just continue to offer, to offer, to offer, to offer. You know, and just because we can doesn't always mean we should. You know, there are some people where living on a ventilator and tube feeding in a nursing home is a perfectly acceptable way to live. There are a lot of people where it's not. And so how I came to be in palliative care was I worked on a cancer unit. My clinical background is social work. I worked on a cancer unit and I worked in an ICU. And I just sat next to people's beds and listened to them say things to me like, if I had known that surgery would have resulted in blah, blah, blah happening to me, I wouldn't have done it. Or if I had known I was at risk to be more debilitated and not be able to live at home because I chose to do these things that were recommended for my disease, I wouldn't have done it. And palliative care is a very grassroots movement from healthcare people who started about 20, 25 years ago, just hearing these stories and thinking we can do better, because I could look in your chart and tell you 5 years prior to us having this conversation that you were going to be faced with some of these things and that the potential outcomes were not in alignment with your goals. So this is really saying, how do we have this conversation earlier? How are we walking people through the way they want to live when they have a chronic illness? So the truth is, palliative care and hospice, if you think of it like a Venn diagram, the middle section's actually really, really small. You know, we do see people as their conditions progress all the way to hospice qualifying, and we do help transition them to hospice. But really, these are people in our community living with chronic illness. So like I said a long time ago, you probably had a chronic illness for 5 years, and then your doctor would tell you it's time for hospice. In 2025, you can have a chronic illness for 20. And the last 6 months of life is what hospice does. So who's helping you with that other 20 years, 15 years? That's us. Mary, does that answer your question?
I'm guessing her audio is off.
Okay. Mickey, thank you. I think, yes, I am aware of this relationship with Cascadia, and I think that's a great way to educate the community. I appreciate that call out. Marie, thank you. Okay, are there any other questions? I love all these questions.
I have one more, I think, quick one. I was a director of a hospice many, many years ago when hospice was just starting in this country. And we didn't, as you said, we did not have palliative care then. And in our community, palliative care sprang out of hospice because we couldn't meet those earlier needs. Anyway, we had a number of patients who did so well under hospice care that we call them graduates. And they outlived the 6-month parameter. Could they, in this program, go back into palliative care if hospice has really done a great job with them and they need to?
Yeah.
You know?
Yeah, so all our hospice graduates get an automatic referral to palliative care. So if you're so kind of, yeah, the way that works for other people on this call, if you're on routine hospice care, which most patients are, you have benefit periods. So we sign you on for a benefit period that's 60 days. And at the end of that, we go out and reassess. Are you still meeting criteria for hospice? And like Catherine was saying, sometimes hospice comes out and really manages all your symptoms and showers you and your family with love. And we get to the end of the benefit period and it's like, oh my gosh, they're so much better. Like now these physicians do not think their prognosis is 6 months. They think that hospice care has extended their prognosis. which is a true story. Actually, people think, oh, well, I can't say yes to hospice because that means I'm going to die. People actually live longer who have elected hospice than continue with aggressive treatments. So that's another piece of knowledge to know. But yes, then when people graduate hospice, they get a referral to palliative care.
Thank you.
And so
Good
we
to know.
can talk to them and make that connection, because they will qualify again, right? And we want to make sure then that they're being cared for and that they have a connection if their situation changes.
Mary Lynn? Oh,
Yeah, go ahead, Barbara.
oh,
I was just gonna,
just quick question. Do you have a brochure for palliative care? I mean, I don't want you going out and spending a lot of money on it because I don't like that kind of stuff. But I'm a pretty current person in senior care living, you know, the service here at PeaceHealth, and I've never seen a brochure for you guys.
Oh, well, that seems problematic. We do have a brochure.
Great. Okay.
Yes. And so I'm trying to think of.
That's good to know. Then yeah. Okay.
Yeah,
They
yes.
they need to have in their waiting room. I'll take care of it.
Okay. Okay.
They're good people.
When a person is transferred to hospice, is it then covered by their insurance? Yes. Julia, great question. So the hospice benefit, it's a Medicare benefit, Medicaid benefit, MedAdvantage benefit. If these two physicians deem you have 6 months or less to live, if your condition were to take its natural course, what's covered under the hospice benefit are all the hospice visits. So hospice, again, is also a multidisciplinary team. You have, you know, a medical director, you have nurse practitioners, you have nurses, social workers, chaplains. So all of their visits are covered under the Medicare benefit. Any medications that hospice is providing you to manage your symptoms is covered under that benefit. And then any durable medical equipment you need. So if you need a hospital bed or a bedside commode or an over tray table or a lift to help get you in and about, those things are also covered under the benefit.
I'm not seeing any more questions in the chat. Is there anybody else who hasn't had a question has occurred to them? They haven't had a chance to ask it yet. Okay. I'm not seeing any raised hands either. I so much appreciate your coming and talking to us about this. This is excellent. This is, and keep up the good work. And if we can help in some way, we definitely would like to. Yeah, we have our
Thank you
marching
so
orders.
much.
After this is over with, we've got to go talk to somebody, explain to them the difference, and support you with. I saw some legislation here, a report that's going to come back to the legislation, and perhaps some bill will result from that, and in other ways too.
Thank you. Thank you so much. I love coming and talking to you guys and answering your questions and making sure you have information. And I so appreciate the support and the partnership and talking to people. So let me know if there's anything else. I'm happy to come back next year and talk. We'll be in touch.
We will do that. Kim, I saw you had two fingers up. Was there something you
Well,
could say?
I was just curious if Donna or Amber had anything to add to this discussion before we say goodbye from the foundation or the philanthropy angle on palliative care.
I said my bit. I'm not sure if Donna wants to say a few words.
I would just, reiterate what Leslie and I know Amber also said, that we just appreciate the community support very much. This is last year and a half or so, the foundation partnering with PeaceHealth and working with Leslie specifically has really been productive, as I think is well told in the stories that she shared with you today. And we look forward to the program continuing to grow and the support of our community behind us. So we really appreciate the League of Women Voters affording us this opportunity to be with you again and share the good works of the program.
So I have one last question for the three of you. Do you feel like PeaceHealth's support of palliative care is deep and solid now? Can the community count on palliative care being there for years to come?
Yes.
Yes.
And I do just want to say, just to put things in perspective and to give a thank you. You know, I've been a palliative care clinician for 20 years. So because of our reimbursement structure, you know, things get tight, there's pressure. The one of the first places they go, right, is let's reduce the palliative care program. Those guys don't make us any money anyway. So over my 20 years as a clinician, I've seen, you know, and I've been in programs and I've had my job cut, you know, where these things are cut. And then it's like, oh no, we've cut palliative care. This is creating such a mess for all these other service lines and the throughput and our community and the patient need. And then we rebuild it. And then we come on financial hard times. They say, oh gosh, let's cut this service that doesn't make us any money. And then they cut it. And then they say, oh no, that was a terrible idea. So over 20 years, I've just seen this happen a lot. So it's challenging. People say, why are you still here doing this? If you could wake up tomorrow and your job could be gone, right? And my answer to that is, I mean, one, I can't imagine doing anything else with my time. I am so intensely passionate about this. I believe it is the best care patients with chronic illness get. It is so needed. And so as long as I have a job, I'm going to do this work. The other thing is every time it gets cut, people think, oh, you got to rebuild from the ground up. It actually comes back stronger, right? That acknowledgement from the community, that acknowledgement from the healthcare system, that acknowledgement from everyone around of like, oh, no, they don't make money, but they do an awful lot. They add a lot of value. They help out in all of these ways, right? We come back we're like a phoenix, right? We just come back stronger every time these things happen. And so because I have the longevity in this career, I don't get discouraged about it, right? It's an opportunity then to say, well, how does this feel for you now that you've made this decision? And people say, well, it feels bad and we will not make this decision again. And you say, yeah, good. Okay. Well, let's talk about how to make it even better than it was before you made the decision. You know, like I never let a good crisis go to waste, essentially. And so that's sort of my answer. And the beauty in it is that it is grassroots. It's always been grassroots. So when everyone else says, we do not abide by this decision, when the foundation said that, when Donna said that, when the community said that, people said that, it helps, right? And so the beautiful thing is it's not just me sitting here as the director advocating, right? It's a whole community and layers of people who believe in the heart and the spirit behind this work. And that's why we're still here. And that's why every time we go somewhere, we come back stronger. So thank you.
And thank all of you for coming and explaining this to us and sending us out with such a positive message. That really means a lot. Thank you very much. Okay.
Thank you.
I don't see any other questions, more of a comment, Sue?
I couldn't find my hand to raise it. So I just decided to do it the old way.
It works.
My understanding is that palliative care, basically because a lot of the services are up front, costs a lot more than hospice care. And therefore, hospice care, in layman's terms, makes money. Palliative care does not. It's also my understanding that hospice funds do not go back to palliative care. They go elsewhere in the hospital system. What is being done to try and put those two together since they're so closely related?
That's a great question, and I very much appreciate it. Part of why hospice, I guess, makes money, as you can say, is their reimbursement structure is so different from ours. So hospice is not on a fee-for-service reimbursement. They have a daily rate. So it's saying every day this person is on hospice, they get a payment for it, right? So if you have a patient, and again, it works similarly. A lot of the work on hospice and cost is to get you on the service initially and get you comfortable and set up. And then there's more work on the end when you start to really decline, making sure you stay comfortable in those last days. But in the middle, right, ideally we have happy, symptom managed people interacting with their families. And so, but hospice still gets that rate. So that's how the reimbursement works. So if our reimbursement worked the way hospice does, we would also be good, but it doesn't. So part of that, why that is just the difference in the reimbursement structure. And then PeaceHealth has done something really smart that a lot of people don't do. But we are under the same umbrella. So PeaceHealth has a home and community service line. So that is home health, palliative care, and hospice. So when home health and hospice have a margin, they give it to me. Mostly because of their acknowledgement that I help transition people to hospice. I help have people on hospice longer. I help have people ready to move to hospice sooner. That's a benefit to hospice. So they give me some money back because I give them some money, right? And in home health, we have a lot of people where these are homebound patients. That's the criteria to get on home health. If you are a homebound patient, you very likely have a chronic illness and are needing some support. Home health clinicians are really there to help meet your goal within a certain time frame. So they consult us constantly to have these larger, more zoomed out, big picture conversations. So the two of those services are a huge support to my program.
Are all of the financial benefits from hospice going to either palliative care or home health? Or are some of them going to other parts of the hospital system?
The large majority of them come to me.
Okay.
So the hospice director and I are like this.
Okay, I mean, I think that there's some communication that needs to go out. The question about palliative care pamphlets and a lot of people not knowing about them is unfortunate.
Yeah.
And that the last time the palliative care program was eliminated, a big discussion went around, it was too expensive and we couldn't fund it. And that was coming from the hospital. So something needs to happen in that,
so
in that
the
area.
reason,
And then all of a sudden the foundation is picking up this, and the foundation can come and go.
so the reason I'm happy to have this conversation, the prior model on a fee-for-service Medicare reimbursement did not have the right discipline set up. So they had a lot of physicians. The physicians cost a lot of money and are reimbursed the same way as a nurse practitioner. A nurse practitioner costs about what a nurse costs and is reimbursed the same amount as a physician. So you get nurse practitioners in there, they're almost a budget neutral position. So in an outpatient palliative care program, it doesn't make a lot of sense to have a large number of doctors. So that was one of the things tipping the wages and the return. So you work to control those costs. So we have a medical director, which is a doctor who oversees all of our nurse practitioners, but then we largely employ nurse practitioners for that reason. And this is the other reason then we're working on that social work billing, because then a portion of that discipline becomes reimbursable. Then if you work on contract optimization, you can have some of the nursing visits in the outpatient setting also reimbursed. So the positions then that the foundation are funding that become really hard to reabsorb become the pharmacist and the spiritual care. Luckily, I've recruited the pharmacist and the spiritual care from the spiritual care and the pharmacy program with the commitment that they would reabsorb them if the foundation funds went away. So in terms of individuals' livelihood, I take that really seriously. I am a single mom. I own this house. I pay this mortgage. I pay the bills, and I got kids, right? And I take people's livelihood very seriously, and I'm well aware that support could go away. So it's, how do I absorb that position if it does? And if I can't, where are they going to go? Where they're still employed with the system. So that is the work that I have done, because that's a really important thing to me, is taking care of the people who take care of the people.
Thank you for doing that. That is important. I would agree.
Kim, I'm going to turn this over to you now because I have to leave. So bye, everybody, and I will be talking with you again.
Thank you, Mary Lynn. Well, are there any other questions before we all say goodbye?
Kim, I would like to ask Leslie a question. This is Marie Eaton, and I want to come back to the question I was trying to phrase in the chat, which is I understand that corporate has a responsibility at that level to, to fund the hospital and to make money, but it seems as though that takes a larger priority over the care aspect. And so, one of the challenges that we had the last time when the palliative care program closed is that decision was made at the corporate level and not here in this community. And so what kind of education can we be doing with corporate about the values of this community and why palliative care is so important to us and why we have been willing to step up and fund it, but that's not the model that can last in perpetuity. So the question, I think the larger question for our community is what's the ways that we can educate corporate about the balance between revenue coming in and all those savings that you're talking about.
Yeah. So that's exactly my point. So I've worked really hard in the last year to create the data that I just showed you. Most palliative care programs in our country do not have data like that. So I got put in the director role after the cut, right? And so then my biggest thing was, how do I fortify this so that this doesn't happen again? And a big part of it was saying, I have to be able to show our value. So again, I don't tell my team, go out and get everybody you can on hospice because that does this and increases hospice length of stay and that has a financial benefit to the organization. I'm not doing that. I'm saying, how do I figure out a way to measure the side effects of good clinical patient-centered care and report that back out to my organization so they know, yes, I do not make you money. I'm not going to make you money. I can optimize lots of contracts. I do believe in my heart that palliative care is on the same journey hospice was. There will come a day someone reimburses us different and we will make them money. And then this conversation is moot. We're not there yet, however, but we're getting there. We're getting there. It's moving, it's changing, the dialogue is shifting. And so I believe we can get there. We have to keep advocating. We have to keep fighting. So the data is my saying, if I have a bad month, I can say, yeah, I didn't make as much money as I normally do in revenue. I saved the system $3 million. You're welcome. And so I meet with the system chief financial officer quarterly, just me and him. And we sit down and I go through this data with him, bullet point by bullet point by bullet point. So although my clinical background is in social work, I went and got an MBA in healthcare to be able to do this job because I thought I can translate palliative care clinically to anyone, right? I'm talking to a cardiologist, this is the benefit to you. I'm talking to an oncologist, this is the benefit to you. And then it really came down to this, and I thought, I'm gonna need a business degree for this. So I went and got one. So I can look at a general ledger, I can navigate these conversations, I can sit down with the system CFO and say, this in a total home and community budget roll-up, might not always add up. But where we fall short, we've quadrupled to the rest of your system. So your response is not, we're in financial crisis, we need to cut you. Your response is, thank you. And I say, you're welcome.
That your data are wonderful, and I hope that you share that data with Nico Jansen, who's doing the work with the palliative care benefit work group at the state level, because that's exactly what they're working for, is a palliative care benefit on the insurance side. So congratulations on collecting such great data.
I want to add to that, Marie, I appreciate all your comments. And that is my question, because essentially I see the palliative care program in hospice. It's really in the palliative care, you are advocating as a team, you're advocating for people with chronic conditions. So as you displayed on your graphs and so forth, you are saving healthcare overall immensely. And so why insurance companies don't sign on to this, because it's so beneficial to their cost saving bottom line, is really surprising. So I didn't know that, Maria. I'm glad that there was a group working on this at the state level, because, you know, it's so important. And that's where the confusion comes in, I think, constantly between palliative care and hospice programs, is that anyone that hears palliative care, they think it's an end life 6-month final thing. And we know people, as Catherine said, people can graduate from hospice. So it's not always that, but the palliative care is really essentially helping these people with so many different chronic conditions live their life. And so I think that is really, because if you look, I mean, hospice is kind of like a specialized palliative care, if you will. So, you know, anyway, I just wanted to make that point, that I don't know how much work you do directly with insurance companies, especially some of the bigger ones like Kaiser and so forth, and trying to advocate for, you know, insurance reimbursement for this, as well as hospice, which is already happening. So that was just my only comment.
Yep. Thank you for that. I do, so my data was sort of phase 1 to going to insurance companies, right? So now I'm able to say, black and white numbers, I save you this amount of money by existing. And so that then opens a door to a different conversation. When it's anecdotal, when it's, I think I save you money, that is not going to have somebody want to give you more money. When it's saying, I know I save you money, and this is how I know, that's a very different conversation. So the last year of getting this data and being able to show it month over month over month over month for all of our programs across the system's really critical to that conversation. Thank you.
Bravo, Leslie. I really applaud you and thank you for taking it on yourself to learn the financial language and to get the credential that allows you to have a stronger voice in those meetings. So many, many thanks to you for that, and for coming back to us and giving us this update. I hope it's not the last.
No, it definitely won't be. And thanks to all of you guys too. Like I said, this is not the palliative care in no way, shape, or form is the Leslie Show. I could not do this without all of your knowledge, all of your advocacy, all of your inquiries, all of your partnership. So for all of the patients in our community that have benefited from this, thank you.
Okay. Well, and thank you everyone for attending today and bringing your presence and your good questions and your interest in this topic. So a good day to you all. And once again, thanks to Donna, to Amber, and special thanks to you, Leslie, for being with us today.
Thank you.
Okay. Bye-bye.